All right, welcome to our second IARS Virtual Education webinar today. We're pleased to present the anesthesiologist's role in reducing the impact of the opioid crisis. And we'll take the first about 5 minutes to do some housekeeping and introductions. The topics today will be separated into 3 different small talks. First, the epidemiology of the opioid crisis and advocacy. And then Dr. Karsten Bartels will speak about the pathophysiology and risk factors of pain and hyperalgesia, followed by Dr. Christina Hayhurst, who will talk about perioperative opioid use, opioid-sparing strategies that improve outcomes. So we have a fantastic year of virtual education ahead of us in IARS. Registration for upcoming sessions is now available on the website at iars.org. If you are a pediatric anesthesiology provider, we strongly encourage you to join our Smart Tots webinar on July 13th to hear the latest pediatric anesthesia neurotoxicity research news. Join us on May 15th and 16th to connect with other IARS members in a dynamic virtual web education experience for the anesthesiology community. You can visit meeting.iars.org for more information about that. The IARS are proud publishers of Anesthesia and Analgesia and ANA Practice, providing valuable research and practice content to the global anesthesia community since 1922. The IARS COVID-19 resource newsletter highlights key articles from dozens of peer-reviewed journals, providing the most useful information for physicians on the front lines. So that's something that you should look at. This particular program today has not received any commercial support. Following this webinar, you'll receive an email directly about how to claim your CME. If you complete the post-event survey, you'll be redirected to our CME website. A recording of this webinar is available to IARS members at the website listed right there on the link. During this webinar, you can submit questions for us, the speakers, via the chat box here, and we'll address those at the end of the time frame. So let me introduce to you the speakers. Hello, I'm David Edwards. I'm the division chief at Vanderbilt University in Nashville, Tennessee. I come by a long road from Edmonton, Alberta, Canada, and did my training up and down the east coast of the United States, most recently in Boston, where I practiced via telemedicine and telepain to Martha's Vineyard before coming here to Vanderbilt for the last 7 years, where I direct the pain services here. My research is in the long-term outcomes of opioid exposure around surgery, so basically our topic today. We have a couple of other great speakers for you today. Dr. Karsten Bartels is an intensivist and a cardiothoracic anesthesiologist. He also did his training at MGH in Boston. He did a pain medicine fellowship, a cardiothoracic anesthesiology fellowship, and critical care medicine fellowships across MGH, Johns Hopkins, and Duke University. He also obtained a PhD at the University of Colorado and an MBA at the University of Colorado as well. He has special research interests in patient safety and clinical outcomes in perioperative medicine. Dr. Christina Hayhurst graduated from University of Arizona College of Medicine in 2009. She attended the University of Virginia for anesthesiology and finished a critical care medicine fellowship at Vanderbilt University in 2015 and joined faculty, and she's been on faculty here with me and a colleague in many research projects here at Vanderbilt. Her clinical work is mainly in cardiac and burn ICUs, but she's an expert in the topics including opioid-induced hyperalgesia in the critically ill population. All right, so now we'll switch to our 3 topics, and we'll see you at the end for questions and answers. Please remember to submit them via the message chat function here. This is the first of 3 talks on the anesthesiologist's role in reducing the impact of the opioid crisis. And this one is focused on the epidemiology of the crisis and introduces a small portion on how to become a community activist. I have no disclosures other than I am a member of the Tennessee Chronic Pain Guidelines Committee and do some activist activities there. I'm also the president-elect of the Tennessee Pain Society. Here are the learning objectives as written in the description of this slide presentation, but we're going to jump right into it. This slide shows drug overdose deaths in the United States for the last 20 years. During the first 10 years on this graph, you see a slow increase in the number of drug overdose deaths. This coincided with the treatment of chronic pain, primarily using prescription opioids. During the second 20 years and most recent years, this epidemic has changed to a syndemic of multiple substances. Prescription opioids represent about a quarter of the opioid-related overdose deaths at this point. They are now primarily the result of highly potent heroin and synthetic opioids like fentanyl, which were injected into the illicit market, and thus you see a rapid increase. Suddenly, the pool of available opioids is more highly potent and lethal. This slide shows it in more detail in the last 5 years. The number of opioid-related overdose deaths continues to increase even up until last year, still going up. It's primarily going up as a result of this brown line here, which represents synthetic opioids, primarily fentanyl, an adulterated illicit opioid supply of highly potent fentanyl. In this article from MMWR this year, we see that deaths due to synthetic opioids like fentanyl are occurring in these high trafficked states in the central United States along the highway corridors. Now, what about data specific to our field of anesthesiology and surgery? Well, post-surgical prescription opioids are the major source of hospital-prescribed opioids at discharge. You can see the incidence of chronic opioid use after surgeries is around anywhere from 6 to 10% at 90 days across all surgeries. And this is data from within the last 5 years. One of the reasons is there's a high incidence of post-surgical pain, 60% at 12 months in some types of surgeries. The prevalence of chronic pain is high in the United States and in Canada and other countries. In the United States, there are an estimated 50 million people that live with chronic pain. There are an estimated 20 million people live with high impact chronic pain needing to be treated with medications, procedures, or see a doctor. 11 million people misuse opioids, and an estimated 2 million people have an opioid use disorder, according to the NISDA National Survey. Now that represents the iceberg below the water behind the opioid-related overdose deaths, of which about a quarter of those contributed to by prescription opioids. Now I wanted to throw this slide in here to show how, anesthesiologists like ourselves, Lozada, Roman, and others who published this in Pain Medicine this past year, are taking care of those with chronic pain, and especially as experts in controlled substances are the ones managing these prescriptions these days. Look here, from 2013 to 2017, amongst most other specialties, there's been a decline in the percentage of prescribing opioids for pain. Amongst pain management providers in physical medicine and rehab, which also is a specialty in pain management, and amongst primary non-physicians or advanced providers, there's been an almost matching increase in the number of prescriptions for opioids as patients as laws impact patients and other specialties reduce their prescribing, the patient flow is towards these specialists. It is us and we who are taking care of these patients. And thus, it's nice to see that we as anesthesiologists are involved in the development of guidelines to treat pain, to develop enhanced recovery after surgery protocols, to take all of our expertise in non-opioid treatment of pain and multimodal therapy, and together with other disciplines, use education as a way to impact and mitigate the opioid epidemic. Now, if you are interested in getting more involved, let me propose that it is through policy and advocacy that you can be very effective. As you know, health is influenced by other things than healthcare, including politics. And, if you look through the literature, few efforts have been made to leverage population health evidence to facilitate policy change. There are three challenges that I see. The need for overarching advocacy groups like our AAPM, like our ASA and IARS. But we also need special issue leaders like yourselves, someone who's interested in this, willing to take it to another level, and willing to take entrenched institutions and use their expertise to translate what the researchers are producing, the evidence base for and against the use of opioids in special situations, and translate that for policymakers and activists. We also need people who are unbiased, meaning they're managing their conflicts of interest carefully, not beholden to any special interest groups, and not a major beneficiary of what's going to be enacted. We call this kind of person a policy entrepreneur. Now, this type of person is a political and social actor. They are able to articulate a specific problem and push for policies that promote change. A real nice outline, and I recommend this article to you from Bayland and Catapali, really outlines what a policy entrepreneur is in population health. Paul Kearney described 3 habits of successful and effective policy entrepreneurs. Number 1, you have to know that agenda setting requires exercising power to generate attention for some issues over others, like opioid overdose deaths over COVID-related deaths. And that brings to point number 2, knowing that timing matters. Perhaps right now, in the middle of a COVID pandemic, is not the right time to be emphasizing and sending all resources to the opioid epidemic. And so now is a good time to build coalitions. As an effective policy entrepreneur, now is the time to define the problem, build the solutions, build the coalitions, and wait for your wave or wait for the opportunity. Policy entrepreneurs are masters of timing in demonstrating their solutions at the moment of opportunity. To become a policy entrepreneur, there is a need to study the uptake of the empirical evidence. So read up on health policy entrepreneurship itself if you haven't heard about that topic. Start now by controlling your conflicts of interest, so you are a trusted advocate. There is a need to develop frameworks for population health to engage with politics. So learn to anticipate the windows of opportunity. Center yourself between researchers, coalitions, and policymakers. Make yourself a trusted partner who understands the literature and is able to translate it to those who don't. Work with researchers as a liaison to translate their research into policy. So get involved, become connected, and then become a connector. Prepare documentations, get involved in the HHS guidelines or CDC guidelines or local strategies. Come up with frequently asked questions that can help define policy in your state or in your country. Prepare strategies that define the problem using evidence and create evidence-based solutions. In fact, and in summary and conclusion, you've seen in this talk that the opioid epidemic evolved into a syndemic of polypharmacy, whereby multiple substances, illicit and otherwise, are used in combination, and the results are all the risks and none of the benefits, including overdose death. Number two, you as an anesthesiology expert are ideally situated to become a policy entrepreneur and interpret the nuanced evidence base that is emerging, whereby substances are used in low doses to avoid the risks in a multimodal analgesic situation instead of a polypharmacy situation. It's this kind of nuanced understanding of the evidence base that is needed to impact policy making, to impact guidelines, laws, both local and national. And finally, prepare for the window of opportunity. We've all been treating our patients in the ICUs with COVID-19, and most of the resources are going there, but the opioid epidemic has continued unabated and is increasing. So wait for that window to reappear. Prepare the documents now, prepare the plan and the solution, and become a policy entrepreneur to help mitigate this epidemic going forward. And now we'll transition to the next two topics and look forward to their presentations. Thank you for your attention.
Welcome to IARS Virtual Education, and thank you for letting me present on pathophysiology and risk factors for pain and hyperalgesia. I do have some financial relationships. I have a grant from NIH NIDA, and I get some royalties from Wolters Kluwer for a book that I wrote. My presentation does include discussion of off-label or investigational drug use. FDA wants you to know about it, to consider it carefully, and to know that that is off-label. The objectives of my talk are to discuss the pathophysiology of pain, to give some examples for neuropathic pain, to discuss some of the treatment options with a special focus on adverse effects from non-opioid therapy, and maybe touch on some future directions in the field. There is a new definition for pain, and the first author on this paper was my chief when I was a pain fellow, so I feel somewhat connected. And it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now that sounds familiar, but what's new here are 6 keynotes to provide valuable context. And they are that pain is always a personal experience. Pain and nociception are different phenomena, and pain cannot be inferred solely from activity in sensory neurons. Through life experiences, individuals learn the concept of pain, and a person's report of an experience as pain should be respected. And although pain usually serves as an adaptive and I would say protective role, it might have adverse effects on function and social and psychological well-being. And lastly, verbal description of pain is only one of many behaviors to express pain. I think that links to the fact that the visual analog scale is completely inadequate to capture pain. A very brief review on the basic route of pain transmission upon noxious stimuli. So you can see the little piece of hairy skin there, and that's where it starts. Peripheral nociceptors sense a noxious stimuli that is then transmitted through the first order neuron that sits in the dorsal root ganglion into the dorsal horn of the spinal cord, where there's the first synapse, and then it travels upwards through medulla and midbrain to the sensory cortex. Well, in the case of neuropathic pain, there has to be nerve injury at some level. And following that nerve injury, there's usually a dense influx of immune and glial cells distal to the nerve lesion, and that extends all the way up to the dorsal root ganglion. That might not be that surprising, but it also occurs at the level of the dorsal horn in the spinal cord. If you do an animal experiment where you induce a peripheral nerve lesion and then a week later check in the dorsal cord, you will see that dense influx of glial cells into the dorsal horn. I wanted to include this slide to highlight that neuropathic pain is a really all-encompassing catch-all phrase. It includes prime examples of neuropathic pain, such as trigeminal neuralgia or postherpetic neuralgia, but it also captures post-amputation pain or central post-stroke pain, which are obviously very, very different in etiology and pathophysiology, and also in the treatments that would be required to treat in a causal way. Pharmacotherapy for neuropathic pain in adults. Well, I want to point out that if agents such as the ones listed here are used in the manner that they were designed, their efficacy is poor, very poor. Let's look at gabapentin. This is a meta-analysis, 3,500 plus patients. And you can see that the number needed to treat for gabapentin was greater than 7. So more than 7 patients had to be treated to find one where it halfway works. And what do I mean with halfway works? Well, efficacy here, as was defined, yes, no, as whether or not the patient reported at least 50% reduction in pain on a visual analog scale. So if you put that into context with sort of the value and relevance in terms of being a clinical outcome measure, that's a very poor measure to start with. It doesn't include anything about functional status or anything that maybe you could say really matters. So take-home message is these drugs work poorly, even if used in the manner that they were designed for. And gabapentin, per FDA, is designed to treat postherpetic neuralgia and epilepsy. That's it. And many moons ago, the adverse reactions were highlighted. They include dizziness, somnolence, and peripheral edema. Let's put that in the back of our heads. In 2006, and 4 of these authors are my teachers, and I'm grateful to them. They did a meta-analysis, at the time only 424 patients, in the context of using gabapentin for acute postoperative pain. The outcome was pain on a visual analog scale here, immediately following surgery, so up to 4 hours. And they found it was somewhat efficacious. Patients who got gabapentin had less pain. But what they also found was that these patients had more sedation and drowsiness, not surprisingly, maybe. Well, let's fast forward to 2019. This is a study from Karthik Raghunathan out of Duke, and they did a huge retrospective claims-based analysis in more than 170,000 patients, looking at the association of adverse pulmonary outcomes with the use of gabapentinoids, actually. Pregabalin was included here. And they found that patients who received a gabapentinoid had a 1.6-fold increased odds of having an adverse respiratory event, here defined as the use of naloxone, after surgery. Well, there are, as we learned from Rob's study earlier, some advantages to gabapentinoid. And here, the use of opioids was reduced in the patients who got gabapentinoid. It went from 83 to 81.4 milligram on the day of surgery. Now, that was clinically significant, but I think one would agree that it is, it was statistically significant, but one would agree that it is clinically completely meaningless. Fast forward to last year, another updated large meta-analysis on this topic Now we're up to not 281 patients, but 24,000 plus patients. And you can see the authors looked at post-operative acute pain 6 to 72 hours after surgery as the primary outcome. They measured it on a 100-point scale. And they found that on that scale, immediately after surgery, there was a reduction of 10 points. So that's a 1-point reduction if you were to use a 10-point scale. And then if you look farther out, 2 to 3 days, there's essentially no difference whatsoever. What about the side effects? Well, visual disturbance and dizziness, for example, pretty significant risk ratio here of 1.9 or 1.25, favoring not using this drug. So conclusions from these authors: no clinically significant analgesic effect for the perioperative use of gabapentinoids was observed. There was also no effect on the prevention of postoperative chronic pain and a greater risk of adverse events. These results do not support the routine use of pregabalin or gabapentin for the management of postoperative pain in adults. Future directions should include matching analgesic therapy with pain phenotypes, and that sounds sort of intellectually intuitive maybe, but what we really have to do, of course, is see if that works. And our clinical trials need to focus on known adverse outcomes. Often in anesthesia and perioperative medicine, we have went down rabbit holes that were intellectually appealing, but turned out to be bad for our patients. Think insulin beta blockers. My care and research philosophy is to minimize iatrogenic insults to our patients. And if you find that exciting and interesting, please join our team, and especially our research team at UNMC, and do reach out. Thank you for your attention.
Hi, thank you for that introduction. I'll be talking about perioperative opioid use and some opioid-sparing strategies that improve outcomes. To start with, I have no conflicts of interest to disclose, and this is not going to be a talk where I tell you to just replace all your opioids with gabapentin and everything will be fine. What I propose is that we think about opioid use in the perioperative period in a more comprehensive, systematic way, starting with preoperative expectation management, where patients should not expect to have zero pain after surgery, to intraoperative multimodal opioid-sparing anesthetic techniques, managing patients with multimodal regimens postoperatively, and then being thoughtful about how much opioid we send patients home with. And while all of this is a focus on reducing opioids in the perioperative period, that translates into improving functional outcomes for patients. So we're not just trying to reduce opioids to say we reduced opioids. It's really to improve functional recovery. And of course, this is in the setting of the opioid epidemic. So you can see on the right, the United States uses significantly more opioids than any other country in the world. In 2018, we represented 5% of the world's population, yet we used 40% of the world's morphine, 45% of the world's hydromorphone, and 20% of the world's fentanyl. And unfortunately, COVID has only made this worse. In September, the AMA issued a brief reporting increases in opioid-related overdose deaths. The CDC did the same in December, and JAMA published an editorial noting that while we had some improvements in 2017 to 2018, it looks like 2020 will be the worst year on record. So this is not going away. And perioperative opioid use is one of the targets for opioid reduction. We know that each refill and week of opioid prescriptions is associated with a large increase in opioid misuse among opioid-naive patients, and that new persistent opioid use can be considered one of the most common complications after elective surgery. In one study, 6% of patients after major and minor surgery were refilling their prescriptions 90 to 180 days post-discharge. So I just want to talk about how one center has approached perioperative opioid use in a comprehensive, systematic way. And that we did that by starting the Vanderbilt Perioperative Service. It was started by this guy, Dr. Matt McAvoy, but we have a very large team of anesthesiologists that see these patients. We've put in quite a bit of infrastructure in order to have such a systematic approach. You can see the periop attending works with residents who organize the block team. These residents perform preoperative epidurals, regional blocks for our patients with a regional attending. And then we round with the rounding team. That team consists of residents, interns, nurse practitioners, and occasionally a fellow. And we round on all of the post-surgical patients that we're seeing, which turns out to be about 25 patients per day. We write all of the orders for their post-operative analgesics. So there are no surgery residents ordering IV hydromorphone in the middle of the night. We take care of all of their post-operative pain. And this is our team up seeing the patient. You can see we're asking him to do his incentive spirometer. And the reason for that is that our goals with our opioid management and our analgesic management is to, of course, optimize patient comfort, but really it's to improve the functional recovery. So in minimizing opioids, our goal is to keep you comfortable, but get your bowels moving quicker, get you able to eat and drink sooner, be able to use your incentive spirometer and walk around, because that will get you back to your life as soon as possible. And then minimizing opioids to minimize side effects, including respiratory depression, ileus, itching. And of course, we can't have such a comprehensive strategy without collaborating with our surgeons. So we work very closely with them to have the same goals for their patients. And Dr. Dimachowski, one of our surgeons, has said that this effort has not only improved patient satisfaction and pain management, but also improved length of stay and utilization of hospital resources. And that, I think, is because of our focus on functional outcomes, not just reducing opioids to say we reduced opioids. Some of the functional outcomes we care about are nausea. So of course we know opioids are associated with nausea. This is a meta-analysis looking at 14 trials who looked at opioid-free anesthetic versus opioid-inclusive. And you can see the opioid group had 24% PONV versus the opioid-free group with 14%, and they had no differences of pain at 2 hours post-op. Ileus is one of the major barriers to discharge for us. It increases hospital costs, length of stay, and 30-day readmission. Low serum albumin prior abdominal surgery and acute and chronic use of opioids are risk factors for ileus. And specifically, the use of IV opioids is a modifiable strong predictor of prolonged post-op ileus, with one study finding a dose of 2 milligrams of IV hydromorphone a day associated with increased risk of ileus. So the surgical guidelines recommend preventing ileus by using opioid-sparing analgesics, such as a thoracic epidural, and treating it by stopping opioids. And then this is sort of the linchpin. If you do an opioid-free anesthetic and you manage them on the floor with a multimodal technique, and then they get sent home with 30 days of opioids, we're still putting opioids out in the world for misuse or diversion. And we know that this happens. Study of 18,000 patients undergoing surgery, 37% of those patients did not require opioids in the 24 hours prior to discharge. However, almost half of those patients in the salmon color there were sent home with a prescription for opioids. And surgeons might say, well, if I don't send them home with enough, then they'll just come back to me and ask for a refill. But in looking at your probability of getting a refill postoperatively, it didn't matter whether you went home with 8 pills or 30 pills, the probability of you getting a refill was still 8.7%. So sending patients home with a minimal amount they need is ideal. So how did our service, with these functional goals in mind, perform in a systematic approach? How do we do it? So we start with expectation management preoperatively, and then we just use a standard ERAS protocol. So gabapentin, acetaminophen, and then everybody gets a regional technique. So a epidural for open case or tap blocks for laparoscopic case, and this is just in our colorectal patients. Patients have an opioid-free anesthetic that involves lidocaine, ketamine infusions, and ketorolac. If the patient has an obvious need for opioids, we don't avoid them completely just to say we didn't use them. If they're opioid dependent, we will, but we try to avoid them. And then postoperatively, like I said, we follow these patients on the floor. We run a lidocaine infusion for 24 hours. We know from a Cochrane review that laparoscopic abdominal surgery has better pain control compared to placebo with IV lidocaine, and then schedule out their multimodals. Opioids available as rescue, but we try to use oral opioids and avoid IV. And then critically, we make discharge recommendations. So since we're the ones seeing the patients managing all of their pain, we tell the surgeons, you know, this patient hasn't used any opioid in 2 days, please don't send them home with any. And so this is the data looking at pre-implementation and post-implementation of this pathway. You can see the red is phase 0, that's pre-implementation, and phase 1 and 2 in the green and blue our post-implementation. We significantly increased the use of regional techniques, epidurals and tap blocks, as well as all the other multimodal components. And that reduced our intraoperative opioid use by quite a bit. You can see 35 MMEs down to about 5. And it reduced our postoperative opioid use as well. So in the PACU, our opioid use went down. But again, this isn't just reducing opioids to say we did, we care about the functional outcomes. So this is the percentage of patients receiving the multimodal component post-implementation on the floor. We increased the use of ketorolac, acetaminophen, and gabapentin, but significantly reduced the use of PCA and nausea, which is one of those functional outcomes we care about. And we also reduced length of stay by about 1.1 days with significant cost savings to the hospital. We don't, unfortunately, have data on ileus because it was poorly defined, but we are in the process of collecting data on our post-discharge opioid prescriptions. And because of these functional improvements, our administration has asked us to work with not only the colorectal surgeons, but several surgical service lines. You can see these are the surgical service lines we work with currently, and we are adding more. So to summarize, this was an excellent review article in this month's Anesthesiology, looking at opioid-free and opioid-sparing anesthetics. And they summarize a great algorithm as to how to approach patients in a comprehensive way. So first, of course, identify high-risk patients and procedures. Preoperatively, patient expectation setting. Intraoperatively, multimodal analgesics, use of local and regional blocks, opioid sparing as possible. Postoperatively, pharmacologic and non-pharmacologic approaches where you titrate your multimodals. And then crucially, pain control after discharge, determine the analgesic prescription needs. Don't send them home with more opioids than they need. So to conclude, we're still in the midst of an opioid epidemic, unfortunately, and COVID has only worsened overdose deaths. Perioperative opioid use affects long-term opioid use, recently found to be at 6%, and a systematic approach to the entire perioperative period that includes multimodal analgesic protocols and opioid-sparing anesthetics have been shown to contribute to functional outcomes, including a reduction of postoperative opioids, length of stay, and nausea. Thank you very much.
All right, thank you for those talks. We have some great questions that have been coming through. Very interesting series of questions, and I'll start with the first series of questions from Charles Wang, who perhaps will ask Karsten Bartels to take the first stab at this one. But I think it's probably there's 3 speakers here, and we might have 3 different ways of thinking about this. So why don't we all take a stab at some of these questions. Charles Wang says, we primarily deal with acute pain. Seemingly a few years ago, pain was the 5th vital sign, and undertreated pain was associated with spinal cord windup and poor patient outcomes. Now there's a push for avoiding opiates. What appropriate weighting of these 2 competing priorities should we use? How can we apply chronic pain specific phenomenon and data to the acute pain settings appropriately? And what are we doing in the OR that we must avoid? You want to take a stab at that, Dr. Bartels?
Yeah, thanks, David. I think that's a great point that you make. And, I think any time when very broad-based policies like, the pain as a 5th vital sign campaign come in and take away clinical judgment, by tying opioid treatments, for example, in the PACU to a VAS pain scale rating, we get ourselves into trouble. And for me, that really comes down to having an individualized approach. And when we do our clinical research, to look out for the adverse outcomes that are known with our treatments. There's no free lunch, for anything that we do, even like with gabapentin. I think what Christina outlined and, the approach at Vanderbilt is wonderful. It's a comprehensive team-based effort where they look at every patient. There's a warm body physician at the bedside thinking critically of what's best about this individual. And that's why, anesthesiology is a profession and we have a bright future.
Christina, why don't you, Dr. Hayhurst, why don't you elaborate on that? But there's another question that's directed to you. It says, Dr. Hayhurst, I'm so jealous of the deal you have with your surgeons. I work in a teaching hospital in Brazil, and my experience is totally different from yours. Surgeons don't want us involved in the postoperative care of their ordinary patients. But when it comes to some of those, patients, the figures are very different. I still use, when I'm allowed, gabapentinoids on the for acute pain, although definitely aware of the latest publications on that. I think they're an important strategy to decrease some opioid doses, and in their hands, they're pretty safe. What's your opinion on some of that?
Thank you for the question. And thank you, Dr. Edwards and Bartels, for your talks. They were great. I really enjoyed them. Our agreement with our surgeons is actually really very helpful. And I think it's because we have the same goals for their patients. And so if we can work together to get to the same goals, which are improved function, get you out of the hospital sooner, then they're more than happy to work with us. I think, and part of the cost savings, again, is getting them, decreasing their length of stay. And so they are all for that. They also, initially, when we work with these new service lines, many surgeons don't want to give up control, which makes a ton of sense. And so it's making sure you communicate really effectively with them is how we've been able to do it. Because I think if they gave up complete control and then we weren't talking with them, they would just feel kind of left out. In terms of the gabapentinoids, we do still use them in very low doses. We are quick to take them off postoperatively if patients are having side effects like what Dr. Bartels talked about, because they do reduce opioids, but they are associated with increased side effects, as he showed us. So we do still use them, but we take them off if patients are having side effects.
And I'll add a little bit of my perspective. I spend at least 50% of my time in the chronic outpatient world, preparing patients for surgery as they're headed in if they're high risk. For example, if they're on Suboxone or things like that. I also see the back end when patients have come off of Dr. Hayhurst's service and those who are optimized and doing well, we often don't have to see because they've gotten off their opioids really well. But some of them are high risk and are on opioids longer term. And it's helpful to have an anesthesiologist or specialist on the back end paying attention to that and managing their function so they're improving, they have confidence. Just someone with them helping them come down on their opioids often makes it more likely that they'll come off. And so I'm really interested in the secondary outcomes of these studies like gabapentin. Jen Ha last year came out with, she's from Stanford, and she came out with an article on the randomized controlled trial and came up with the same primary conclusion as these articles where, pain wasn't changed in the acute perioperative time period, but patients got off of their opioids 25% faster if they were on them. So it's really helpful in my outpatient world. I'm trying to get patients off of their opioids if they're already tolerating a low level of gabapentin or a low level of memantine or these other multimodal analgesics. So for me, the secondary outcomes are of primary importance. All right, there's several questions here that are really about the technical things of these types of services. Why doesn't Dr. Bartels or Dr. Hayhurst just chime in really quick? What doses of lidocaine infusion do you use, intra-op and post-op?
We weight-based dose it, so intraoperatively above 80 kilos, we'll use 2 milligrams and below 1.5, and then on the floor, 1.5 or 1.
Is it the dose or the duration of opioid use that's the critical risk factor for an addiction, do you think, Dr. Bartels or Dr. Hayhurst?
I think the question of addiction is the big question. And the, all the HEAL money that went out, and David showed that in his slide that we haven't made a dent in overdose deaths. And I think it's easy to label somebody as long-term opioid use. That's pretty objective. Unfortunately, mental illness has such a stigma in society that labeling somebody with a diagnosis of opioid use disorder carries much more weight and is much more complicated for a variety of reasons. And we actually don't have a good handle on what the incidence of addiction after, let's say, opioid use in a previously opioid naive patient is. All this, big studies always use this chronic opioid use outcome as a sort of a surrogate. But I think, philosophically, I think the answer to this question is really in destigmatizing mental health issues and addiction as a disease like the flu.
Great, thank you. Praveen Ganti in Toronto asks, is there any evidence for using magnesium along with ketamine in the peri-op period for the synergistic effects to prevent transition from acute to chronic pain after major surgery? I'll start by saying I don't know of that evidence. Dr. Bartels, do you have any thoughts on that?
I'm unaware. Whenever we try to find a silver bullet for a huge problem like this, it usually fails. And again, I would really commend what you're doing at Vanderbilt. It's a bundle. Not everything has to be effective for everybody. And then you go to the bedside and actually fine tune your bundle intervention by pouring a lot of resources into it, and that's the way to go. So I'm not saying magnesium never works, but I would certainly not set up a protocol where everybody suddenly gets magnesium.
And just physiologically, just thinking about it, it's an interesting question. And if you're using that or considering using it, I would really love to kind of hear your experience. So please do get in touch. Magnesium is the plug inside the NMDA receptor, and that's the similar site or same site to where ketamine is acting upon. So we're always looking for, during surgery using ketamine for analgesia, but you can't use it high doses after surgery because of people hallucinate and people have side effects. But magnesium's also acting in the same site, and people could tolerate that longer term for sure. That's one reason why we switched and started using things like memantine as well. But magnesium might be a good option. And then looking at those long-term outcomes would be definitely important to see if we can prevent some of that chronic pain development. It's a very interesting question. Thank you. Are there Yeah, sorry. Go ahead. Sorry.
I was just going to say, I agree with Karsten, and it is a bundle. And so honestly, nobody knows, there's not a silver bullet, as he said. So we are going to be looking into that, doing a platform trial with ketamine, similar to the SMART trial, to see if we can tease out what are the most effective parts of the bundle, what makes a difference and what doesn't. So hopefully we'll have some more data.
Are there some analgesics in the pipeline that you're aware of with hope to transform pain management?
I mean, there is a lot in the pipeline, focusing on TRPV1, for example. But I think there will be likely better drugs, but we have to continue all of our efforts in order to tackle this problem. We might get some support from new medications and new ways to treat pain, but it's not going to solve the whole issue, I think.
Some that I'm aware of, at least fields and groups of development, a lot of money in the United States is going into that, nearly $1 billion of research last year for pain. And some of those that are being developed are, genetic studies have identified the different receptors like the alpha-2 and certain medications that we use for other things like guanfacine for ADHD are the most specific receptor is in the alpha-2 receptor in the trigeminal ganglion. So for facial pain, it might be something that's really, really beneficial if we use it in that area. Other areas are things like like I mentioned, memantine, which is used for Alzheimer's, but it's also an NMDA antagonist. So people are starting to reach out to these other fields where medications are already approved for other indications, so we can get there faster. These medications are already being tolerated in other populations, but they may be helpful in pain. So that's definitely one avenue. Another big field is, how can we use opioids more safely, right? How can we prevent their side effects? And so there's an avenue of blocking the reward. There are drugs out there being developed to block the reward of the opioid when you give it, so that you can give it safely. It's not causing you to develop an addiction. And so these are just some that I'm aware of. Another good perioperative question here in complex pain management. Has the use of Suboxone and like drugs made our job of pain management in the perioperative period easier or harder? From John Rawlingson. Easier or harder, Christina? Dr. Hayhurst.
Hi, Dr. Rawlingson. Dr. Rawlingson taught me how to do thoracic epidurals as a resident, and it was the director of our pain service. Excited to see you. I personally, just in the perioperative service, I only see these patients inpatient. Find it somewhat difficult, although doable, especially if Dr. Edwards sees them preoperatively and we have a plan. But I would have to let you comment on the post-operative sort of side of things, or the chronic management. It is nice, though. I think the way that it makes it easier is to have a plan for them, and to have some ability to titrate things, instead of just having somebody show up on large doses of Suboxone and go for a major surgery.
We do have a request from Kristen Howard to help answer that question. I don't know how to turn that function on for you. If you'd like to type your answer in there, I'll be happy to read it back. I think that what we are all learning, and I'll just add my chime into that Suboxone question, is that pain can be managed in patients who are on Suboxone, and it can be managed effectively at the most common doses that patients are on, which is 16 milligrams a day if they're using it for an opioid use disorder treatment. Upwards of 90% of those opioid receptors are blocked. Still, the affinity constant for buprenorphine is about 0.28. And the only other opioid that we use commonly, I guess some of us use commonly, or we did in the past, is sufentanil. And in what situations are you going to use that? They're rarer and rarer at this point. But the next one closest to that is hydromorphone, or Dilaudid, at 0.3 approximately. Fentanyl somewhere around 2, and oxycodone's around 15. So if you really want a chance in heck of outcompeting that buprenorphine, probably in the perioperative period, hydromorphone or fentanyl are your two options. Fentanyl because it crosses the blood-brain barrier because of its lipophilicity. It gets there in higher concentrations faster. But the bottom line is we're learning ways to treat patients while they're still on it. Some groups I know, like MGH, will reduce the Suboxone at least on the same day of the surgery down to 8 milligrams in patients at risk, which frees up a few more of those opioid receptors and allows for pain to be controlled. And what we all, in my world, on the back end, it's really helpful when a patient has made it through successfully and they're still on it, so I don't have to re-induce it. I think that's the most important thing. If they come off, sure, we can control their pain, but a lot of them don't ever get back on, and that becomes really difficult to manage after that. Let's see if just wanted to look for that comment if it came through. Are there studies assessing the incidence of postoperative persistent pain in opioid versus non-opioid use? Very good question.
Yeah, there might well be. I can't cite one off the top of my head, have to be quite honest. I think that the whole concept and, that issue of anesthesiology that Christina mentioned was all about that, of doing, opioid-free analgesia for surgery is sort of emerging, and long-term outcomes have yet to be defined. And again, I would like to still caution, it is an appealing concept, but there's no free lunch. So we definitely have to look for that. I think it's a great question.
Agree. I think it's a great question. I think we do also know, though, based on what Dr. Edwards showed us, is that we still have quite a problem with persistent post-surgical pain in general with our current practices, which generally, for most places, are using opioids as our primary analgesic. So we have a problem either way, but I also don't know of any specific studies, but we still have a significant amount of post-surgical pain.
We'll keep going right to the bitter end here. 5 more minutes, and we'll try to get in as many as your good questions, but they're really coming through right now. So thanks to everyone. Dr. Hayhurst, how do you manage patients who are on long-term opioids for chronic pain?
So we evaluate patients, look at their opioid doses. We do not do opioid-free anesthetics or opioid-free postoperative management. We don't completely take them off their opioids. We usually put them on their home dose plus a small increase, but we continue all the other multimodal regimen along with their opioid use, and then try not to escalate their dose at discharge by over 25 to 50%. I don't know if you have any other comments on that, Dr. Edwards.
That sounds about what we do, isn't it? Yeah. Sometimes, it is interesting. You get patients on these enhanced recovery protocols and you expose them to some of the medicines that aren't opioids and they feel better. And they're like, why do I need to go up higher back to my home dose? I feel like I don't need as much anymore. And now the strategy is, how do you get them out the door on less opioids if they don't need it? That's always an interesting experience.
Would you comment just on your ONET calculator?
Yeah, sure. So a couple of years back, we were trying to set up what's called a transitional pain service. And I saw some of you from Toronto on here who originated this concept several decades ago. And what that is pre-op, peri-op, and post-operative treatment and management and coordination of pain care. And so, yeah, what was your question? Oh yeah, the ONET. So we created an ONET criteria, which is, stratifying patients as they're coming through by their naivety or their exposure or their tolerance to opioids, and then modified it by any other thing that modifies your risks for prolonged opioid use, which could be the kind of surgery that you have. If it's major and it's painful and we expect you to be on opioids long term, or if you have uncontrolled anxiety or depression, those are all adding a level of risk to this condition. And then actually my nurse practitioners in the chronic pain clinic are all experts in this criteria at this point, have worked in the clinic and on the inpatient service. And we have a system of stratifying and communicating across the continuum of care. And, it's just in its early years compared to the Johns Hopkins program and Duke and Toronto, but we're doing it in a system that works with our enhanced recovery programs and our perioperative service that Dr. Hayhurst is on. So, do you use methadone on major ambulatory surgery? Could be a good strategy in multimodal analgesia. What do you think, Dr. Bartels?
Well, did Evan Karish ask the question? No, but no, I mean, it is an appealing concept, and there's been, Dr. Karish has done some important work in that area. Again, I think, we have to test it in larger studies. We have to look at things like QTC prolongation, and, you got to be careful. Those would be my comments on this.
Can anyone comment here to elaborate that a little bit further? There was a follow-up question similar. Can you comment on the recent findings in anesthesiology on methadone plus ketamine versus methadone on post-op opioid administration and other functional outcomes? Anyone familiar with that topic recently?
No, I'd have to to give a competent answer, I'd have to look at it more carefully.
Yeah, me too.
So I have to give it a pass.
Just in not knowing the study, but thinking about it in our experience, Dr. Hayhurst, we have some of our protocols where if we are going to give an opioid, the opioid that we recommend is methadone. That's for our bariatric surgery protocol, is that right?
Mm-hmm. We use methadone as our primary opioid on most of our inpatients. To comment on the ambulatory question, as our rescue opioid in the PACU, but not on the floor.
Yeah. Have any of you had an experience with the 5% lidocaine patch in acute postoperative pain?
The patches are appealing because they don't have a lot of side effects, but they don't have a lot of primary effect either, because the tissue penetration is so superficial, and in the case of a chest tube, for example, you're just not going to get to that depth of the intercostal nerve. So appealing in concept, no side effects, which is already a big plus considering other options, but probably not very efficacious.
There's another similar question here, so I'll couple them together a bit. But yeah, exactly what you said, Dr. Bartels. Sometimes we do cut those patches up and stick them around small incisions when you have that, pain that's really superficial where it can be effective. So sometimes in combination with other things, it can be really useful if the pain is localized. But there's a follow-up question. Are there any comments on the long-acting local anesthetics, either currently available or forthcoming?
I would say they've been a disappointment overall. And, the concept of preemptive analgesia sounds very appealing, but if you do an animal experiment, for example, and use long-acting bupivacaine prior to nerve injury, the animal will do better initially, but the longer-term outcomes will be very, very, very similar and the same. So those would be my comments on that topic.
I think we are out of time, and there are so many still really good questions out there. I'm going to try to save some of these questions, and this discussion has been recorded and will be on IARS.org for the next year. And I'll see what some of our Kristen, Howard, and others, if others know, whether we can maybe have some of these follow-up questions answered in text on our website. But thank you for your attention, everybody, and thank you, Drs. Bartel and Dr. Hayhurst, for your time and your presentations.
Thank you.
Thank you, everybody.